Okay, we're going to have a look at psychological disorders. So I'm going to bring that up on the screen for you. And the first portion, the introduction to this topic, we're going to start by looking at the definition of psychological disorders that's found in DSM-5. DSM-5 is the Diagnostic and Statistical Manual of Mental Disorders, the diagnostic tool that is used by mental health professionals to determine if an individual has a particular disorder, as well as DSM also contains considerable information about those disorders. We'll talk a little bit more about DSM-5 after we've looked at the definition and some basics. So DSM-5 then indicates that a mental disorder is a syndrome characterized by clinically significant disturbance in an individual's cognition, emotional regulation, or behavior. Let's take just that much and take it apart. So there is a significant disturbance. There is something that is out of the ordinary in this person, which involves their cognition, in other words, their ability to think and reason, to process information. That might include memory as well. Or the disturbance is in emotional regulation, the ability to control their emotions. This might include, for example, the person getting down into the dumps for weeks on end and not being able to pull out of that depressed mood. Or a disturbance in behavior. So the person may be doing things that are dysfunctional, as we'll look at in a minute, things that don't make sense. Or they may be doing things that are detrimental to their ability to function on a day-to-day basis. Okay, so let's continue then. Significant disturbance in one of these areas that reflects a dysfunction. Okay, what's a dysfunction? Well, the DYS always indicates the opposite of something. So this is what? Something is not functioning as it should. Something is not functioning according to the definition in the area of psychological, biological, or developmental processes. So some psychological process is not working as it should, or there is a biological process is not happening as it should. Notice these kind of indicate, well, sort of more or less causes of those disorders. There is a psychological cause or a biological cause, or thirdly, there may be a developmental dysfunction. The person's development is not proceeding as it normally should. Okay, so we have in this portion of the definition that there's a significant disturbance in one of these three areas, and that this represents a dysfunction in one of the three areas mentioned there. Going on, DSM says mental disorders are usually associated with significant distress or disability in social, occupational, or other important activities. So usually we're going to see significant distress. What is distress? Something that's very uncomfortable, right? Something that's very unpleasant. Or disability. Disability is again the opposite of ability, right? So the person is unable to do certain things. This might be in the area of social activity in terms of their relationships. They may not be able to maintain good relationships with others, or in the area of occupation. So the person may be unable to do their work as they need to as a result of this dysfunction that we talked about. Now, what about students? Do students have an occupation? Yes, their occupation is, at least one of them, student, right? And so students, this may affect them in the sense that they're unable to do their schoolwork effectively as a result of the disorder. Or other important activities, such as what? Taking care of one's family or taking care of oneself. The person may be unable to fully do these things as they ordinarily would. So let's go on. It continues. An expectable or culturally approved response to a common stressor or loss, such as death of a loved one, is not a mental disorder. Okay, so if this is something that is typical in a particular culture or group, we don't call it a mental disorder. And they specifically mention death of a loved one. Now, when DSM-5 came out, when this new revision of the Diagnostic and Statistical Manual came out a couple years ago, many people in the mental health community were appalled that there was no longer a disorder that would indicate the person grieving. And so many of them thought that if somebody was sad and depressed for more than 2 weeks and so on, showed other signs of depression after the loss of a loved one, which we would normally probably see due to grieving, they thought that you would have to diagnose that person with major depressive disorder. Well, not so. Right in the definition, that says, it tells us here that this is not a mental disorder. This is an expectable, culturally approved response to a very intense stressor, death of a loved one. But in general, then, we're going to say mental disorders are going to have this element of distress or disability, or maybe both. The last part of the definition, I bet you couldn't believe it was already, there's even more. It goes on to say, socially deviant behavior, whether it's political, religious, or sexual, and conflicts that are primarily between the individual and society are not mental disorders unless the deviance or conflict results from a dysfunction in the individual, as mentioned above. There's a whole lot there to take apart, too. So, what about socially deviant behavior? Is that a mental disorder? Well, first of all, we have to know what's deviant behavior. If you've studied sociology, you might have learned in that course that deviant behavior involves two basic things. One would be a behavior that is statistically rare. It is not common in that particular cultural group, unusual. And secondly, in order to be considered deviant, that behavior then violates the norms, what is thought to be appropriate within that cultural group. Okay, so we might think of, for example, pedophilia as being something that is deviant behavior because it is not common, thank God, although it exists and all too common, but not common. And secondly, though, it goes against the norms of our society. It is something that just about every person is going to say is not right. Okay, so this deviant behavior, whatever it might be, is considered a mental disorder only when it results from one of those dysfunctions that we mentioned before. Dysfunction in the person's psychological functioning or biological or their developmental functioning. Okay, so if it's not tied to that, it may be something that's not good, maybe, okay, although some deviant behaviors seem to be kind of harmless, but not pedophilia, obviously. Having said that, any deviant behavior that doesn't result from psychological, developmental, or biological causes is something else other than mental disorder. Okay, now there's, by the way, maybe let's talk a little bit more about deviancy here and how that influences the diagnosis of psychological disorders. So, is going naked deviant behavior? most of you probably said, yeah, that's deviant. We don't do that. People would say, well, that's not right. Yes, in our culture, that's generally the case. Having said that, there are cultural groups where that's the norm, where people don't wear clothes. There's not too many of them anymore, but there are. Or consider if you're maybe at one of those, now for lack of a better word, a nudist camp. Within that particular group, in that setting at least, that particular behavior wouldn't be considered deviant, at least within that group. Now, that said, again, in overall American society, going around naked is considered deviant, not to mention that you could be arrested for it. Yeah, if your instructor from one of your courses were to show up naked for that course, you'd say, yeah, there's something wrong with them, right? That's not right, and obviously not common. Now, let's take it a step further. Well, what about a belief in ghosts? So, the person believes in ghosts. Is that deviant behavior? Now, you might say, well, we don't have much proof that these things exist, if any. So it may be, in many cases, kind of irrational, but is it deviant? Well, if we look at, again, American culture, it appears that at least 40% of the population is open to the possibility that ghosts might exist. So because it's not an uncommon belief, we'll have to say this is not in the category of deviancy. And so we don't diagnose you automatically with a mental disorder because you have the idea that ghosts might exist. Now, having said that, if you start to tell us that ghosts are taking ideas out of your brain when you're trying to take a test, and ghosts have broken into your car and stolen your textbooks, now we're going to look at some other indicators of mental disorder to consider whether maybe there's some other things going on here that might suggest psychological disorder. Here's another example that we'd have to consider in certain situations. What about hearing the voice of a deceased ancestor? Is that deviant behavior? Well, usually when people in our culture say they're hearing voices, we start wondering if they're okay. But in certain cultural groups, certain, for example, Native American groups, their belief traditionally has been that when an ancestor passes away, that you will actually hear them speak to you, and some people have those experiences within that group, is considered perfectly normal. So in deciding whether to diagnose that person with a psychological disorder, if this is the only thing that we're seeing and it's part of their traditional beliefs as part of that culture, we're not going to call that deviancy and look for a way to diagnose them with something. Now, that said, again, if there's other indicators of mental illness, then we might look to those to see whether there's something there. Okay, last part of the definition. I promise you this is the last part. The definition also says conflicts that are primarily between the individual and society are also not mental disorders unless the deviance or conflict results from one of those dysfunctions that we mentioned. Okay, conflicts between the individual and society. So we have a person and they they don't like how society's going, so they're going to go and they're going to protest what's going on. Is that a mental disorder? No, not unless it results from one of these dysfunctions. If something is not right with them psychologically, biologically, or in terms of their development, is being the cause of that, we don't call that a mental disorder. Okay? Or here's another example, and this may be one of the reasons this is in here as part of this definition. What about if a person disagrees with the government? You might say, well, yeah, there's a conflict between them and society then. unless, again, this is due to one of these dysfunctions we previously mentioned. That's not a mental disorder. Where that maybe has shown up in the past. If you're familiar with the old Soviet Union, what now has been broken up into many countries, one of which is Russia, in that Soviet Union, if you disagreed with the government, they then could diagnose you as having a mental disorder. You must be crazy if you disagree with the government, and they could put you into a mental hospital literally for the rest of your life, simply for disagreeing with the government. Maybe that's one of the reasons this is in there, to prevent that from happening. Okay, so there you have your definition. Aren't you glad that's over with? Now, in terms of ancient understanding of psychological disorders, well, the idea of psychology and all wasn't around yet, but when people behaved in bizarre or ways in which they were unable to function within society, often this was attributed to demon or spirit possession. And so they might bore holes in the person's skull to try to force the evil forces to leave them. Now that began changing when Philip Pinel in France and some others came along and suggested that abnormal behavior may be due to an illness of the mind. And so they suggested that this might be similar to a physical illness having a physical cause. So this brought in then the medical model of mental disorder. One of the things that influenced this is physicians found out that syphilis could cause dementia, loss of mental capacity, and that syphilis then they found caused by a germ. So this supported that medical model, and other things like they found out that exposure to mercury could cause hallucinations. So they began connecting our physiology, our biology, with mental problems. Even today, many medical terms are used when we talk about psychological disorders. They might talk about the etiology of that disorder, how its cause and how it developed. We might use the term diagnosis, that being a medical term of identifying symptoms and distinguishing one disease from another. Or the idea of treatment for a mental disorder also is sort of medical language. Think of the idea of treating a disorder in a psychiatric hospital, for example. Or the term prognosis. That is a medical term in terms of a forecast about the disorder is going to get better or worse and so forth. So we've borrowed a lot of medical terms to describe mental psychological disorders. Most psychologists then today are going to see psychological disorder from the biopsychosocial viewpoint and recognize that there could be biological influences, that we may be adapted for certain environments. If we're encountering different environments, that this may lead to problems, or that there may be individual genes that predispose people to develop certain mental disorders, or that there might be abnormalities of brain structure or brain chemistry that lead to that disorder. They might also recognize potential psychological influences. For example, exposure to high levels of stress or constant stress, being exposed to a trauma, some situation where one is in great danger or there is great harm that's done, or the experience of learned helplessness, which we talked about in a chapter on personality, or maybe mood-related perceptions and memories. That mood might bring forth certain perceptions of how things are going. Like, for example, when as a person's in a down kind of mood, their perception of things is they're more likely to notice bad things happening and ignore things that are good. And when the person is in a low mood, they're going to remember all the bad things that happen rather than the good things. It's mood-related perceptions, memories. So these and many other things might contribute to the development of that disorder as well. And then social and cultural influences, the roles that that culture expects of that person and whether they're capable of performing those roles, other expectations that the culture has of them, as well as how that culture defines what is normal and what is disorder. So whenever we encounter psychological disorder, we need to look at all of these as being potentially causative influences or risk factors. So, a little bit about DSM, Diagnostic Statistical Manual of Mental Disorders. This is the classification system that is used to identify psychological disorders. It's produced by the American Psychiatric Association. It does not indicate how the disorders are to be treated, only how we identify them. DSM-5 is the most recent edition, came out a couple years ago. In DSM-5, there are over 400 psychological disorders listed, as compared to 60 in the 1950s. Now you might wonder, well, what's up with that? Why so many more disorders nowadays? Is that there's really that many new and different things popping up? Well, not so much. What the main reason that we have many more disorders listed is they are becoming more precise in defining that disorder. And so what might have been one disorder 50 years ago now has become a dozen different, more limited disorders. So that gives the diagnosis a good deal more precision. Some people also would suggest, well, maybe the addition of more disorders is also a matter of trying to classify more behaviors as disorders. Psychiatrists might find that useful in prescribing medication. That's a question that would take some discussion to get into. So here's some of the features of DSM-5. It describes the disorders on the basis of symptoms, also indicates how prevalent they are, what percentage of the population suffers from that, whether it's more male or female, what cultural groups or socioeconomic groups might be more impacted by it, and so forth. Provides information about associated features, other things that tend to go along with that disorder, and then information on the course of the disorder. Does it get better, worse, constant? Does it go away? Does it come back? So forth. The diagnosis that was produced by DM4, the previous edition, was fairly reliable. In other words, if several different professionals were asked to diagnose the same person, they usually came up with the same diagnosis. We don't have enough information on reliability on DSM-5 yet, but it's likely to be similar in reliability to DSM-4. Maybe even a bit improved according to some people. Now here's a criticism of DSM, and this was both DSM-4, DSM-5 as well. Some criticize DSM puts any kind of behavior within the compass of psychiatry. So if we have a person who's having some sort of difficulty, there's almost always a way to come up with something in DSM that we can pin on that person as a diagnosis. And some would suggest, well, there are things in there that maybe should not be considered psychological disorders. If you have a problem with gambling, there's compulsive gambling. Some of us would say, well, no, this is a bad habit, this is bad conditioning, but it's not truly a disorder. Well, we could argue that. Or how about stuttering? Yeah, that's in there too. And so we might argue again that, well, maybe is that more of a neurological problem sometimes rather than psychological disorder. So we're going to argue some of these things as to whether they should be considered psychological disorders, but nonetheless they've been included there. Now, how is having these diagnostic categories useful? Well, for one thing, it does enable mental health professionals to communicate very readily. If someone sends me a client who has been diagnosed with bipolar disorder, I know that that person has had periods of time when they have experienced a manic state for a week or more, and they've also had periods of time, or will have periods of time in the future, where they also are depressed for significant periods of time, 2 weeks or more. So right away I know some things about that person's experience based on that diagnosis. Secondly, the diagnostic categories helps scientists to study the causes of these disorders. If we didn't group clusters of symptoms into specific disorders, how would we study what that cluster of symptoms is caused by? But by grouping those symptoms together in that disorder, now we can study what's the basis of it. Also, the diagnostic category, that label, helps the clinician to identify the treatment that might be most beneficial for them. If we again have grouped those symptoms into clusters of symptoms, we can study what treatments works best for that cluster of symptoms, that disorder, and match it up with the individual's problem. So there is some usefulness to this. On the other hand, there are some potential problems that may be associated with the diagnosis of a psychological disorder. Have a look at that baseball team in the picture. At first glance, it looks like any old-time baseball team, but if you look a little closer, the uniforms say asylum. This is an old-fashioned term for a mental hospital. If you were playing against that team, would you maybe play the game a bit different? A lot of people would. They might be watching their backs, worried that the players might do something weird. There is a stigma, a stereotype that has gone with diagnosis with psychological disorder. Probably one of the most common stereotypes is that people with psychological disorders are therefore unpredictable and violent. The surprise is that, in general, people who have psychological disorders are no more unpredictable and no more violent than the average person, with a few exceptions. Certain types of schizophrenia, bipolar disorder, antisocial personality disorder, but those really make up only a small portion of people who have psychological disorders. The rest, no more likely to be violent or be unpredictable. So one of the things that we need to do is educate the public that just because someone has a psychological disorder does not mean that we need to fear them. One of the reasons that this is important is often people are afraid to go for help when they have some psychological disturbance, and the reason being, what would people think? People are going to treat me different. Yeah, that's due to that stigma. We need to get rid of that. Another problem associated with diagnosis with a psychological disorder is the confusion of psychological disorder with insanity. So a lot of people believe if you are diagnosed with a psychological disorder, it means you're insane. It means you're crazy. And once again, this is not an accurate stereotype. One of the places where this pops up is when we have a legal situation. Insanity actually is a legal term, not a psychological term. Okay, so first of all, we are really misapplying it if we're talking about a psychological disorder as being an automatic indicator of insanity. Now, Legally speaking, what does it mean for the person to be insane? It means that they're unable to tell right from wrong, or that they were unable to tell right from wrong at the time they committed a crime. In some states, they will add, or they were unable to control their behavior, even if they did know it was wrong. Texas, it's flat out, a person was unable to know right from wrong when they committed the crime. Now, how many people with psychological disorders will know that they're doing something wrong when they commit a crime? Vast majority. Even people with severe psychological disorders, like this Ted Kaczynski that you see here, he was called the Unabomber and was mailing bombs from his cabin out in the woods. And he could have been diagnosed with, in fact, was diagnosed with numerous different psychological disorders and some very severe ones. Yet, in hearing testimony about his mental state when he committed the crimes, the jury determined that he did, in fact, know right from wrong when he committed those crimes. His appeal for the insanity defense fell through because, indeed, he did know that was wrong. So we have to be careful about assuming people don't know what they're doing just because they have psychological disorder. And of course, that also brings up the question, well, what about mentally ill individuals who commit crimes? Should maybe how they are handled be somewhat different from the general prison population? That's, again, another big discussion that, that we might have that unfortunately we can't do in a presentation like this. So let's get into a few specific disorders. Some of the rest of them will be in part 2 and 3. The first would be neurodevelopmental disorders. This is a new category in DSM-5. So what are they looking at? Disorders where development has gone off course, the person's development, and they connect this then with the development of the nervous system, neuro. Okay, one of these being ADHD, attention deficit hyperactivity disorder. The three main characteristics that you would see of this would be inattention. The person is unable to pay attention, focus their attention as compared to those their age. Most of the time when this is diagnosed, it's going to be diagnosed first in childhood. So inattention as compared to others their age. Hyperactivity, the person is always moving, is always overly active, again, as compared to others their age. And then impulsivity, which is the person is unable to control their behavior. They act without thinking. They can't stop themselves from various urges that they might have. And again, as compared to others their age. How is this diagnosed? Well, we don't have any medical test that is actually effective in diagnosing this. So it's diagnosed by basically observation. Generally, it will be diagnosed by having 3 people complete a checklist. That will be a mental health professional, such as a psychiatrist, clinical psychologist, and yes, sometimes the person's medical doctor. Then also generally the parent of the child will complete the checklist, as well as often the teacher. To be considered ADHD, this person must show these characteristics across the board, not in one specific situation, like not just only at school and so forth. Okay. The difficulty with this type of diagnosis is it's pretty subjective. And so, as an example, if we have a parent who is going down that checklist, the person unable to focus their attention, doesn't pay attention to details, is hyperactive, always moving, can't sit still, impulsivity, talks when they're supposed to be quiet, blurts out in the middle of class, so forth. Anyways, if the parent is going through that checklist, if they've had a couple kids that are pretty passive, that are not so active, but within the normal range, this third kid that they're looking at may seem hyperactive, impulsive, inattentive as compared to the more passive children they've already had. So in contrast, in fact, though, that child might actually be within the normal range. And the same thing in a school setting, the teacher sometimes may maybe even unconsciously check more of those items because the child is a problem, a behavior problem in the classroom, and maybe even intentionally sometimes hoping that they'll put them on medication and help them or something. Anyways, so what this results in is some overdiagnosis of this. Some kids who really don't have it being diagnosed as having it. There is also some underdiagnosis. There are many parents that don't want their child to be diagnosed with it, go through the testing for that because they're afraid of what that will mean if they have that on their child's medical records, or they may be afraid of what the medication will do to the child. So you have some of both sides of that. In terms of treatment, I might just mention that the most common treatment is to provide stimulant medication like Ritalin or Concerta or something like that. However, there is also behavioral treatment for ADHD. And really all kids should get the behavioral treatment. What kids need behaviorally who have this is they need consistent discipline, not harsh, but consistent. They also need checklists and routines. Because they're inattentive, they have to be reminded of things, to bring their homework along, to make sure that they did all the tasks that they needed to do, and so forth. And then there also have been, they found physical exercise can help them, as well as some activities that help them to learn to focus their attention more effectively. Even some computer programs using brainwave feedback have been developed that seem to be somewhat effective. So there's numerous behavioral treatments as well. Some people diagnosed with this, in fact, may be able to cope with it effectively simply with the behavioral treatments and may not actually need to be put on medication. Others, though, in fact, it seems that the medication is absolutely necessary. Even then, with behavioral treatment, often the amount of medication can be reduced significantly. Okay, so there's one example. Now, also we have in DSM-5 what are called neurocognitive disorders. These are disorders where there's a significant decline in cognitive ability to think, reason, remember, process information. And again, they're tracking this to what? The nervous system, to developments in the brain and nervous system. So, two neurocognitive disorders included there are called mild neurocognitive disorder. This one, there is a decline in cognitive abilities that is noticeable, that is significant enough to affect the person's functioning day to day. However, it is not so severe that the person then needs assistance from others. On the other hand, major neurocognitive disorder would be where the mental decline is significant enough that now the person must have others intervene in order to function. So the person is not able to do daily tasks effectively due to the mental decline. Now, in fact, these neurocognitive disorders may be due to any number of things. Maybe due to Alzheimer's disease. They may be due to strokes, it's called vascular neurocognitive disorder, or due to traumatic brain injuries, many different potential causes. This diagnosis, by the way, has replaced the previous DSM-4 diagnosis of dementia. Maybe you've heard of dementia, mental decline. Now the proper diagnostic term is neurocognitive disorder. Let's skip now to some anxiety disorders. These are more common disorders. All of these involve some level of fear, fear being another term for anxiety. So anywhere from moderate anxiety, worry, constant worry to intense terror might be part of each of these disorders. We'll look at three of them: generalized anxiety disorder, panic disorder, and phobias. General anxiety disorder. There is a persistent and uncontrollable tension. The person is tense all the time, and apprehension, so a fear something bad is going to happen. The person worries constantly. The worry is free-floating, so it doesn't focus always on one thing. If one problem is the focus of the person's worry and that's resolved, they begin worrying about something else. It's just constant. The person also finds themselves unable to relax, always tense. Their autonomic nervous system is over-aroused from all of this worry. And in fact, this then may cause physical symptoms and health problems like headaches or like digestive problems, rise in blood pressure. Next, we have panic disorder. In panic disorder, the person has suffered a number of panic attacks. These are brief episodes where the person experiences intense fear. Many people describe it as being a sense of terror, and they might feel physical sensations, chest pains, choking, can't get their breath, shaking. They might feel numb. Other frightening sensations. They also might have very frightening thoughts that they're going to die, they're having a heart attack, that they're going crazy during this panic attack. So a very unpleasant thing. Fortunately, relatively short-lived, maybe 15 minutes, give or take. Okay, give or take about that much on either side generally. But very scary. So the panic attacks sometimes may lead to avoidance of the places or situations where attack has occurred, so the person's activities may become more restricted as a result. Also may lead to a fear of future attacks and the development of generalized anxiety on top of it. This also may predispose the person to be more susceptible to substance abuse. The person might think, well, gosh, if I can just, take a few drinks all the time, maybe I can stave off that panic attack, calm my nerves, but then they become vulnerable to alcohol or drug problem. So notice panic disorder, you have rather brief episodes, very intense fear, whereas generalized anxiety disorder, somewhat more moderate, medium level fear, anxiety, but ongoing, 6 months or more. Okay. Phobias, also anxiety disorder, involve an intense and irrational fear of some specific object or situation that results in avoiding that thing or situation. So the person may be fully aware it doesn't make sense that they have this phobic reaction to that thing, but yet they can't seem to keep it from happening. If you look at very typical fears of people, not phobias but fears, okay, not so intense that we consider it a phobia, you will notice that a lot of these might be things that could have endangered our ancestors, falling off of a cliff, fear, heights, or fear of certain animals, so on. It appears that in many cases, phobias are sort of exaggerated versions of sort of normal fears that we might have. Some phobias are so common they actually have their own names, like agoraphobia, phobia of open places, being in a place where you couldn't get help, whether that's in a crowd or an open field somewhere. or acrophobia, a phobia of heights, or claustrophobia, a phobia of enclosed spaces. So, person with claustrophobia, are you going to see them riding the elevator? No, you're not going to see them there because they're going to take the stairs. Yeah, so here you see the element of avoidance demonstrated. Or hemophobia, a phobia of blood, of being exposed to blood or seeing blood. Some people don't know they have these phobias until they encounter this stuff. We lose a few nursing students every year when the sight of blood first happens and they pass out. Unfortunately, or I should say fortunately, we have very good treatments for phobias. Those nursing students need to be told that, you know what, you can get that treated and overcome that. Okay, so phobias. Now, in explaining anxiety disorders, there are a number of potential explanations. The psychoanalytic viewpoint, concentrating on the unconscious, might suggest that repressed urges or repressed memories might produce anxiety, although the person doesn't know why they're feeling anxious. Learning theory, the behaviorist viewpoint, would say, well, there could be fear conditioning. You might remember little Albert and the rat. And that fear conditioning has generalized then into other situations. If we approach it from the social learning viewpoint, we might say, well, observational learning also could contribute to an anxiety disorder. Maybe we saw someone fall off of a ladder. Now we've developed a fear of heights and so on. From the biological standpoint, natural selection might come into play. We might be predisposed to have some fears and anxieties, and now certain other things have aggravated those. There may be some specific genes that some people carry that predispose them to anxiety disorders as well. And maybe in some cases this can be traced to overactive emotional centers of the brain. So we have a number of potential explanations available. Next on our list is obsessive-compulsive disorder. This used to be listed amongst anxiety disorders. In DSM-5, though, there is a new section of compulsive disorders that this has been placed in. In this disorder, the person has obsessions. Obsessions are mental things, persistent and unwanted thoughts or urges that the person has. They may be mental pictures that come into their mind that they can't seem to rid themselves of. The other part of the disorder is the person also has compulsions. These are behaviors that the person feels compelled to do, that are irresistible to them, usually driven by those obsessive thoughts or urges. So we can see some of the more common types of obsessions in the box here. A concern with dirt, germs, toxins, fears of of contamination. Notice that might match up with a compulsion for hand washing or bathing or grooming of some sort. Another very common obsession of something terrible happening, which might lead to, say, various rituals of checking doors and so forth. Also, you might have some obsessions for symmetry, order, exactness, so the person must line up everything according to certain numbers, or everything must be arranged by height, or you name it. And so that, again, pushes that compulsion. If the person is prevented from performing that compulsive behavior, often they will experience very tremendous anxiety as a result. Notice that one of the criteria for the person to have obsessive-compulsive disorder is it must be at the level that actually is interfering with normal functioning, which it can obviously do. The person with that fear of contamination may not be able to function as a student. As soon as they touch something going into the classroom building, they must run and wash their hands. And yeah, can you imagine how are you going to even sit through a class without touching anything? It can be very, it can interfere much with one's life. Okay, so that kind of brings up something I want to mention is a lot of people think that maybe they have this, when in fact they don't. We all, pretty much all of us, will have some maybe mild obsessions. As an example, who hasn't kind of gotten a song stuck in their head and it keeps playing over in your mind all over again, you know? And it can be kind of annoying. But in fact, were you able to function while that was going on? Yeah, usually people are, right? So it doesn't rise to that level that would be diagnosed by that. Or in terms of compulsions, yeah, there's many of us have some mild compulsions. Like say, as walking along sidewalk, many people sort of adjust their steps so they don't step on the cracks. But if they were to do that, yeah, no big deal, and they do it even without thinking about it. You know. On the other hand, as part of OCD, that person steps on that crack in the sidewalk, and now their mother's going to have a horrible accident, and they must do some ritual to undo that. Maybe they have to jump back and forth over that crack 100 times to undo it. You see, that's where we get into obsessive-compulsive disorder. Well, maybe it's not 100 times, there's only 10, it still might be OCD. But notice this is what more significant than some of the mild things that we might experience that we don't feel like we have to do anything about. Then we have post-traumatic stress disorder. We'll look at that a bit. Again, this was also previously categorized as an anxiety disorder. Now there's an entire section of trauma and stress-related disorders in DSM-5 where this has now been placed. So PTSD may occur when a person is exposed to potentially life-threatening events or other trauma. So things where a person has lost their life or there is significant harm to the person that may come. So this would include things like what? Combat trauma, such as in the picture, but could apply to what? An accident or being the victim of a crime or being diagnosed with a terminal illness, you name it, anything with this potentially life-threatening potential. The statistics indicate that some 5% of men that are exposed to traumatic situations and 10% of women develop this. So not by all means everybody. A small percentage, but still, again, the more intense the trauma and the more that has been repeated, the more likelihood the person develops it. So just what are the responses that are associated with PTSD? First of all, avoiding cues that are associated with the trauma. So avoiding situations that might be similar to it or remind that person of it. So if the trauma was an explosion, that person might be unable to attend the 4th of July fireworks because it reminds them too much of that explosion. Re-experiencing the traumatic event, that can take a number of forms. The person might be just constantly have it on their mind, can't get it out of their mind, re-experiencing in that form. Or they might have nightmares in which that or a similar event occurs. Or the person might have flashbacks where it seems to them that the whole thing is unfolding once again right before their eyes. Any of these are types of re-experiencing it. Heightened arousal. So the person might be on edge. They might be startled by things that the rest of us would not startle to. And emotional numbing. The person may find that they just don't seem to respond emotionally to things like they normally would. This is often very difficult for family members, and they say the person is just not the person they were before. They used to be, say, affectionate and caring. Now they just seem to have no emotions. Also, impaired functioning may occur in terms of emotional functioning and having normal ups and downs of emotions, sleep disturbances, may occur, and so forth. Now we move to some examples of dissociative disorders. As we mentioned earlier, dissociation is a situation where certain mental processes that are normally available to our conscious awareness are cut off from our awareness, where we might not have access to our memories, or we may not be able to tune in on our thoughts or feelings that we would normally be aware of. Or maybe it might involve also physical sensations that normally we could be aware of that we no longer can feel. Now, people frequently have dissociative experiences at times. That's not necessarily part of one of these disorders. It's not uncommon for a person to have a few moments of a sense of depersonalization when they feel like they kind of just don't exist as a person for a short moment. Or maybe a sense of derealization where they're looking at events that are going on around them and it just doesn't seem to be real. The person says it was surreal. I just didn't seem real to me. Those might give us a glimpse of what people with dissociative disorders might experience in a much more intense sort of form. So here's one example: dissociative identity disorder. DID used to be called multiple personality disorder. Maybe you've heard that term. Here the person has two or more distinct and alternating personalities. Chris Sizemore, as an example, had well over a dozen. And so even though one of those personalities generally is sort of the core personality, what we might call the host personality, there are numerous other personalities that take control of the person's behavior at various times. These alter personalities may be aware of one another and what they are doing, although generally the host personality is unaware of the existence of the alter personalities. The person also will find that when they are in the host personality state, that they will not have any memory of what they were doing when they were in alter personality states. Now, they've studied these alter personalities and found that they can be distinctly different from the person's host personality. They may be different gender-wise or age-wise. You might have an adult that has a six-year-old alter personality, might be different in handedness, might be left instead of right-handed, might differ in sexual orientation, response to medications, how they speak, you name it. In fact, these differences seem to be so distinct that even the best actors were unable to fully mimic this by just pretending. It seems to go beyond just pretending. One of the things also that seems to suggest that this is a real and not faked sort of thing in some people is that 95% of people who suffer from this have a history of severe childhood physical and sexual abuse. And in fact, some theories suggest that maybe the dissociative identities then are sort of defense mechanisms, elaborate defense mechanisms to protect that person from the trauma that they experienced, to keep them unaware of what they went through, to help them deal more effectively with the abuse that they had encountered. So that said, the percentage of the population is only a very, very small percentage that have this. There also have been numerous people who claim to have it who turned out didn't. So that might also be some of the basis for some of the concern about this one. Shifting again, we'll look at some somatic symptom disorders. Soma is body, so these are disorders where there is a physical symptom, although the cause of the symptom or the cause of the disorder is psychological. One example being conversion disorder. Here the person has paralysis or loss of sensation in their body that is not indicative of anything being physical wrong. They can be checked out medically and it's determined there's no physical cause for that paralysis or that loss of sensation, it's assumed that there is a psychological cause. The second one on our list is illness-anxiety disorder. In this one, which was formerly called hypochondriasis, the person has a dread fear that they have some grave illness, that there's something just terribly wrong with them, although when examined medically, this is inaccurate. This is then generally based on minor symptoms not indicating severe illness. The person might find that they've got a little rash on their arm and conclude they've got cancer. So this person then goes to the doctor to have it treated. The doctor assures them that's not cancer, don't worry about it. That person then, illness anxiety disorder, is going to conclude that doctor doesn't know what they're doing. So they may go from doctor to doctor, hoping someone will recognize their plight. Eventually, maybe a doctor looking at their medical records recognizes what's going on, prescribes some placebo treatment, and lo and behold, as that thing goes away, the person says, "Oh, this is great." But that's not the end of the story, because very shortly, any other physical symptom, any minor thing, maybe a twitch, is enough to get them worried that they've got some other horrible disease. Now, you all might think that's kind of comical, and a lot of us do, but in fact, for that person, it's horrible. They are in terror constantly that they're suffering from these horrible illnesses. In fact, all the worry that they do about this can actually cause them to actually become really physically ill, develop, say, digestive problems or headaches or high blood pressure and so forth. So it's not much fun for them. Sad to say, the bad news is we don't have any real good ways of treating this either. And so if you've got someone like that in your life, hang on and just hope to cope with it. Okay. So there you go. Okay. So that takes us then to the beginning of part 2. So thanks for listening. Hope you took some notes. This will help you in grasping some of these as we go through that chapter. Thanks. Bye-bye.